Always, I want to say thank you all so much for tuning in, logging on, and just hanging out with me and my special guests for a little while as we get to talk about healthcare. We get to talk about all things compliance, insurance carrier related. And as my special guest is holding up it looks like a coaster from his time on the President's Council. Um, Many of you may recognize Dr. Stephen Soloway. I think we got it, Doc. Many of you may recognize Dr. Stephen Soloway. He was on the program several months back. I think it was episode 22. His episode was one of the more popular episodes simply because he really is the man, the myth, the legend. Um, so I'm excited to welcome Dr. Soloway back. Today is Thursday, October 27th in the great year of 2022. And the reason why I've asked Dr. Soloway to come back onto the podcast is because I will be joining him tonight in New York City for his book signing. And there's so much for us to unpack about this book signing, and it's just going to be a ton of fun. So with that said, my good friend, it is great to see you again. Thank you for being back on the program. Thanks for carving out time from seeing patients to hang out with me and to educate our listeners a little bit more on why you really are the man, the myth, the legend, possibly the most interesting man on earth.
I'm honored to be here. Your introduction cannot be beat. I'm your friend. You make me feel at home, and I like my patients to feel at home. And I'm learning from you how to make people feel at home. It's wonderful. So
We have done some behavior modification training over the last several months. It seems to have paid off a little bit.
yeah, yeah. I'm an unfiltered soul who sees wrong and says what he sees. And, that's not always politically correct, although we don't live in a politically correct world as much as they want us to be politically correct. Political correctness is going to further destroy the country. I mean, it's chipping away at it pretty good.
And it's interesting, and we'll talk a little bit about some of the things that are being done for political expediency over doing what's right for people, regardless of what side of the aisle you sit on, whether you're on the right, the left, the middle, wherever you sit. We're all at the end of the day human beings. We all deserve to be treated in a humane way, and we we all have a right to expect civility from our fellow persons. But I want to start off by talking about your first book just briefly. So your very first book that you put out, I believe it was what, a year and a half ago, almost 2 years ago.
Yeah, about October of 2020, it was when it
Yeah,
first got released. If you don't mind, I want to just add
yeah,
something here, which I find
please.
very apropos to both the book and what you're saying. Talk about decency and talk about practice of medicine. Yesterday, I saw a patient. The patient was 40 years old and very hardworking, eager person. Just help me get better. I'll do whatever you say. Okay, fine. So my assistant, Denise, wrote the order for the medication and said to the patient, go down to the pharmacy. It should be ready, later today. The patient went directly to the pharmacy just to be told, oh, I'm sorry, that requires a pre authorization, and your doctor is going to have to write a letter to the carrier or the pharmacy benefit manager as to why you need the drug. Well, my response was, well, no, I'm not doing that. I already wrote a prescription. That's my letter indicating I want that drug. So why do I need to write the same thing twice when it's pretty clear that if I signed the prescription and I said I want the patient to get bubble gum, then they should receive the bubble gum, and they are insured. So, how is this debate even coming up? So I just wanted to share that example from yesterday, and it blends into my book, which that book was called Bad Medicine. Well, how much worse can it get when you go to the doctor, he gives you advice, and you're not allowed to take the advice because someone else who probably learned how to tie their shoes last Thursday is making the decision as to what you can get and explain a process how your doctor can write a letter on top of a prescription to try to get the medicine that they actually need, but you're in a battle with their boss because that guy's trying to save money so they don't have to release the medicine. And as they scurry through their Google and look for a less expensive version, okay, there you go. So the first book, Bad Medicine, was kind of like the book House of God for the first half of it. It was literally my
Right.
experience in um excuse me, first 2 years of medical school in the Caribbean and everything I saw. Next 2 years in London with all clinical acumen and bedside diagnosis and so on and so forth, and everything that I witnessed. Um, the same goes for my internal medicine training, my rheumatology training, my time in the VA system, and my first handful of years in private practice. And you know, we're a really very smart, brilliant country with brilliant scientists, and we're on the cutting edge of every technology there is. Except it almost reminds me of a football game where the guy who owns the team, who's the billionaire, he's got 20 millionaires out there playing and entertaining him. But the real shtick is that those 50,000 people who are drunk, they're paying his salary so he could pay them and he can keep the leftovers. And medicine is really not far from that at this point.
Yeah, it's been an interesting run, in the 28 years that I've had the honor and privilege to advocate on behalf of providers such as yourself, health systems, hospital networks, suppliers, uh, pharmaceuticals. It's been very interesting to watch the slide, as I call it, into a dark abyss that has put patients unjustly in the middle of a dispute between a physician who is charged with the responsibility of caring for that individual, helping to restore them to a level of optimal functioning, removing barriers, treating the symptoms, treating the signs, and finding a way to take people who are, and I'm going to use rheumatology because you're a rheumatologist, taking patients who for all intents and purposes have lost hope, are, for lack of a better term, in many ways incapacitated because of the inflammation to their joints, their musculoskeletal system, their tissues, dealing with inflammatory diseases, MS, whatever it may be. And then, doctors doing and fighting the good fight on behalf of these patients, only to run into MBAs or business, if you will, I'm using quotations, business people who are making and dictating how care should be distributed to people who are paying their benefits. And I'll stop with this last comment. I got my pay sheet, right, for my 2 weeks yesterday. And it was so funny because I was like, "I've got to bring this up on the program with Doc." I got my pay sheet yesterday, and I was looking at it, and it said insurance premium, 800, and I think it was 897, okay? And I sent it in the email back to my comptroller, and I said, "Am I reading this correctly that I'm paying $897 per month as a single for coverage?" And I won't use the insurance company's name because I don't like to disparage anybody. And she sent it back and she said, "Yes, you are." And I said, "You've got to be kidding me. I'm paying $897 a month in a premium just for myself with a $5,000 deductible. a max out of pocket of $7,500 annually, and I can't get them to pay for any of the medically necessary services. Uh, True story. I could not get my Dexilant that I take. Could not get my Dexilant that I take. Now, the insurance company said, "Sure, you're more than welcome to go ahead and get it, but it's $400 a month." And then I found a coupon and I was able to get it down to $125 a month. And then just by chance, Doc and I were talking, and Doc said, "I'll I'll make sure you're okay." And down the road a few weeks came a package with a year supply of Dexilant. But it shouldn't be that way because my gastroenterologists, my primary care doctors who have been treating me for GERD, I've had upper endoscopies, twice a year. I've had to have throat stretching. I've had to have all of these things done. I've been on every type of antacid that is out there. I've taken everything. Some of the medications were actually causing me to have stomach polyps, which is precancerous if you don't treat them. Yet my insurance company said, "We don't believe you going on to Dexilant is medically necessary." I said, "I'm not going on it. I've been on it for 3 years. Why now all of a sudden do you not want to pay it?" And their answer was, "It's not on our formulary anymore." How is this equitable healthcare? They want to talk about equality in healthcare. The other problem that we run into is we have people who live in rural areas of this country, white, Hispanic, black, Asian, whatever, who are living in rural areas who cannot get access to high-speed internet services so that they can do telehealth visits with their providers. How is this equality in healthcare? It's a joke. It's not. It has become a punchline. It has become a politically sexy term to use, and I hate using that word sexy, but that's really what it is. It's an appealing term when people on either side of the aisle come out and say, "We're going to ensure equality in healthcare." How can you ensure equality in healthcare when we have a massive population that doesn't even have access to the internet to be able to get telehealth services?
The the politicians never let an opportunity by to create a problem. And COVID was an example where you weren't allowed out of your house. You had to start with this telehealth, and all of a sudden, it's the be all and end all. And before telehealth came along, somebody must own stock in the CAT scan company because CAT scans took the place of the physical exam. And back to this terrible tragedy with Dexilant. Here's a drug; it's FDA approved. Okay, here's a drug that somebody prescribed you for some reason. Whatever the reason is, some doctor decided you needed Dexilant. That's the end of the story. That doctor, if he's a real doctor, should not have to justify anything about why he's prescribing Dexilant to a patient. So, whatever the reason is, if a doctor signed a prescription, no, he should not have to go through an appeal process. He should not have to write a letter to justify why he wrote a prescription, because, in fact, by signing that prescription, that was his letter of affirmation that this patient of mine needs that drug. And I don't need to explain it to you because, frankly, that's a HIPAA violation. His health problem, or the reason why somebody picks one drug over another. Um, it's absurd. So absurd, so absurd.
Yeah. Well, let's get into the reason the real reason why we're doing our podcast today. Because tonight I'm joining you in New York City for your book signing of uh, 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 your second published book, which I'm so excited about, and it's called Medical Politics. And I told you, and I told others on my very first podcast that you joined me on, that I had actually cited sections of your bad medicine book in some of my letters back to the Centers for Medicare and Medicaid Services. I've quoted some of your stuff in some of my civil and or criminal trials that I've engaged in, administrative law judge hearings. So, it was really funny that before you and I ever even knew each other, I knew you because I knew your book. So you wrote a book. It was a successful book. I don't think it rose to the level of your expectations because I don't think anything ever really does rise to what we hold ourselves to as an expectation for ourselves, right? I mean, you could have sold 1,000,000 books and you would have said, "Why didn't I sell 2,000,000?" And I guess again that's just human nature. But this book is really, I think, a timely book because our political landscape in 2022, coming into the midterm elections just over a week from now, really about a week and a half from now, on November 8th, some of the most hotly contested battles are happening in your border states, New York, Pennsylvania. I mean, really interesting to see what's going on. But you opted to write a second book, and it's called Medical Politics. Let me stop here and ask you why you wanted to write this book and how you came up with the medical politics topic.
The first book was a success within the realm of the baseline knowledge, knowing that a random author that writes a book usually gets maybe 100 copies sold. And while I did not have an aspiration, say, to become a New York Times bestseller, it's always in the back of your mind because, the guy who's in Little League, he figures if he's going to go to the majors, he should probably go to the Hall of Fame. But, even the book writing system is so corrupt that if you want to be a New York Times bestseller, you merely need to know somebody who's got a super PAC who can buy enough of your books prior to release. And if you hit 5,000, you got a bestseller. Now, if you're a guy like me, it took 2 years to sell 5,000 books. That to me is extraordinary. Here I am in this isolated rural town of South Jersey. Um, I'm surrounded by 25 rheumatologists. However, the perimeter of that 25 rheumatologists is probably 100 miles, and it reaches into Delaware and Pennsylvania, and it goes up as far as Trenton, and it goes down to the ocean on the east and the south. And you say, wait a minute, there's a guy practicing in the middle of all this who nobody knows, and he's got 3,000 YouTube followers, 2,000 out of the United States, and he wrote a book on bad medicine. Nobody knows anything about the book, and it sells 5,000 copies. So I said, gosh, the book talked about all these things. It resonated home with a lot of people, got a lot of feedback on the social media that, hey, you should have talked about this, you should have talked about this. So I started to listen to all the things I should have talked about, and I said, "Gosh, there's enough stuff here, enough material to write another book." So the first one was fun, and frankly, after 30 years of seeing patients day in and day out, I was looking for like a little bit of a diversion. And I thought, what a, what kind of a diversion would be better than writing a book that actually teaches doctors and empowers patients? So the first book has a chapter called Rheumatology for Dummies, and in that chapter, I talk about gout, rheumatoid arthritis, psoriatic arthritis, and lupus. I think there may be a little bit more, but those are the highlights. And that chapter covers enough information for not only it covers enough information for any doctor and any patient of those conditions or family member of a patient with those conditions so that they understand more than their doctor has taught them or told them, because it goes into the finer details and it takes out all the minutia and scientific formulas and whatnot. So it's written practical. So the second book, I said, okay, I'm going to not only do a rheumatology for dummy chapter, but I'm going to expand on it. I'm going to put the really complicated problems that a lot of people have and don't like to talk about: myositis, vasculitis, scleroderma, Sjogren's syndrome, well, common ones, osteoporosis and fibromyalgia. So those are covered on a patient and doctor level simultaneously in the new book, and there's a chapter on medical orthopedics. I like to um, I like people to understand that at least the way I was trained by a world famous rheumatologist, Ralph Schumacher. Ralph was very big into synovial fluid, which is the fluid that comes out of the joint, or I'm sorry, is processed in the joint. And his area of research from 1963 until his death, and 5 years ago, was to analyze fluid and to determine the type of arthritis somebody had by looking at the fluid and so on. So with this type of inquisitiveness thrown into me, I feel like I was trained in the inquisitiveness and the looking at the joints, and our training encompassed needling all the joints. And while the general population feels that needling all the joints belongs to, say, orthopedics, or in the case of carpal tunnel, plastic surgery or something like this, um, a guy who's trained like me, who's eager like me, uh, has to explain to the public in layman's terms and to family doctors and GPs and hospitalists and so on all the things, carpal tunnel, trigger finger. By the way, I have a patent. I actually have several patents, US and international patents on needles, how to
I've
inject.
seen them when I was in your office. Yeah.
Well, there's a reason that my success is higher. And because I have more success and more volume, I get more audits. What does an audit do? It agitates me. Well, when I'm agitated, I say, well, why would I take that insurance? They like to audit me. What's the end game? They basically they want you to pay your copay. They want to audit me and take away the money, but they want the money. So it can't be distributed evenly. It has to be, you have to pay $5,000 out of pocket max. I need to work for free so that the people up at the headquarters, those people can fly on a private jet. It's so anyway, this is what the book kind of talks about. It's everything I just summarized plus some.
Yeah. You know, so I've gotten a chance to read the manuscript. I was fortunate. I was sent an advance copy of it and I read through it. And for me, when I think about how the book is structured and why it's structured the way that it is, and we talk, you talk about medical politics. You're right. We're talking about the the power that is wielded by the big insurance corporations, and the fact that everything trickles down from there. You know, insurance companies are not in business for paying claims for sick people.
That's correct.
They're into business to make money. They're into business to turn a profit, to satisfy the shareholders at their meetings, to ensure that they have proper distributions of profits quarterly, annually, whatever it may be. Now, I I am a believer in the free capital markets, okay? And I believe everybody has a right to make a profit, but my belief in profitability ends when it infringes on the inherent rights of an individual. If I, as a member of an insurance plan, have agreed to pay a set premium each month for coverage of pre-existing conditions that I have or conditions that I may develop as I get older. And to know that I have peace of mind that I will be able to go to a physician of my choosing. I will pay my annual deductible. I will pay my co-payments. And in return, the risk share portion that the insurance company is responsible for will be paid to my provider. Now, look, there's no doubt that there are some bad actors. You find them in every single industry. But in healthcare, and I can say this because I've been doing this now for 28 years. It is less than 3% of the entire physician population who are bad actors that create havoc and chaos and noise for 97% of those providers who are out there who just want to see patients heal, optimize their level of health, and recognize their doctors for the great work that he or she performed. I mean, listen, medicine is not an exact science. It's an art. There's a reason why they call it the practice of medicine. Okay? And when you start running into insurance companies playing doctor, where they're coming out and they're saying, we have denied the service or we're refusing to pay for a service or to pre-authorize the service because we don't believe that it's medically appropriate, necessary, or reasonable. We've got a huge problem, Houston, because last time I checked, insurance companies don't get to decide who, when, and what type of care a patient receives if it goes against the generally accepted standards of medical practice and those determined by a patient's treating physician. So I know I threw a whole lot out there, but I mean, to me, that's where I looked at your book and I said, here's the intersection of the practice of medicine, the business of medicine, and then the politics of healthcare. Is that a fair summation?
You put a lot out there, and I want to address a few things that you mentioned. So the bottom line of the insurance company, that's one issue. How is it that the CEO of a major pharmaceutical company gets a go away package for $150 million, and anybody in that seat gets the same package? So shouldn't the um, whoever regulates the stock exchange, and again, I'm just losing my, I don't know
The
the name.
SEC.
Okay, yeah, yeah. Why doesn't the SEC do some sort of a policy that says for a CEO of a publicly traded company to walk away with over 50 or 100 or 200 million dollars, you need to be in the position for 7 years. You can't be in it 7 months, because if every 7 months somebody's walking out with 100 million dollars, the balance sheet can't add up and nobody can get treated, because there's only so high you can raise the prices before Bill Gates can't buy his medicine either. And meanwhile, every time they rotate this position, there's a severance package of an astronomical amount of money, a couple of airplanes, limos, bodyguards, whatever comes with these positions. Okay, now not to jump all over the place, but you mentioned one of the last things that you mentioned was about receiving the medications and what they should decide, what they shouldn't decide. People need to realize that because this is an art and not a science, and because the squeaky wheel gets the oil, and because the more common diseases are subject to clinical trials, that means that many rare diseases, which let's say are rare to the family doctor and are rare to somebody not in my specialty, but maybe common in my office, those drugs don't have any drugs. I'm sorry, those conditions or diseases don't have a drug or a treatment that is FDA approved, does not equate to we don't have a standard of care. And within the standard of care, there's variation. And I like to say that a common disease can present to you as a doctor in a common or a rare fashion. A rare disease can present in what would be common for an expert in that disease or in a rare fashion. So, knowing that you have these moving parts, day one, the patient comes in, they're sick. You need to act immediately to save their life. Now, if they're in the hospital, the bill is paid almost automatically unless they deny the admission, which is crazy as well, because then you're questioning the judgment of who admitted the patient and why. And again, they're the doctor. But if they come to the office and I decide, geez, this person needs 1,000 milligrams of steroids to live, well, I have to do it. Well, gee, that's not indicated. Well, actually, it is the standard of care. Well, the standard of care according to who? Well, 35 years ago when I started training, we were doing it then and it worked. So it still works now. And you might say, well, gosh, that guy who came in with shortness of breath with relapsing polychondritis or this or that. And first you say, what's relapsing polychondritis? I never heard of that. Well, don't worry about it. That's my specialty because you don't have to have heard about it. Just like I've never heard of pulmonary alveolar proteinosis, which is a rare lung disease. I don't need to know anything about that except the fact that I know it exists. So in my field, a rare disease comes in and I do what is, quote, correct in my eyes. No, there's no FDA approved treatment. So you can't deny anything. As long as I'm making logical sense and helping the person, that's got to be the art of medicine at the finest because we shouldn't even be relying on here, a professor once told me at Boston University, this guy was very, very world famous. I don't even mind saying his name, J. Thomas Lamont. This guy was, this guy was he was the Ralph Schumacher of GI back in the 80s. He wrote all the textbooks and so on. And he once said to me on rounds, he asked me to look something up and I grabbed a book. He started scolding me. He said, "Are you kidding? If you're reading from the textbook, you're out of date. You need to go look up the most recent articles that were written last month." And that resonated. And I followed that up until now, and I still do. And, a lot of stuff that's written in the New England Journal as a brand new article, that's not going to hit the mainstream book or media for perhaps 2 or 3 years. But that doesn't mean it's wrong. That doesn't mean you shouldn't use it. However, the insurance company will say, well, gosh, that new drug, it's experimental. Well, no, not if the data in the New England Journal shows that on 10,000 people it worked. How is that experimental? Why are they writing it if it's experimental? It just hasn't reached the textbook yet. And the lobby or the um, petitioner for the company that makes that drug didn't yet negotiate a rate with the company that's got to pay the bill, and therefore it just doesn't count. So wait a minute, you're telling me there's a cure for what I have, but I'm not allowed to have it because it's only been around for a week. Now,
Yeah.
just look back when COVID started and people were getting monoclonal antibodies. I don't know how long they tested the drugs for. Probably not very long because COVID was new. Yet they gave it to
Right.
the president of the United States. Well, if they really thought there was a risk, they probably would not have given it to him. So why wasn't
Well,
that
I
made
don't I
more
don't know.
available?
I don't know about that.
Well, it depends on what type of doctor it was that day, but
Yeah.
but the whole point is that we have all kinds of stuff that work for all kinds of things, and if somebody simply doesn't like the pricing, then they ban it from their formulary. And what I've done in my office is I'm fighting back. I'm saying, you know, you want me to use drug X, but I don't stock drug X. I stock drug Y because it's been around longer and I'm comfortable with it. And if you have a problem paying for that drug, then I'll match the price of what you want to pay for the generic drug. Now what's your excuse to deny the drug when I know it's the right drug? So I want to start to sue these people for practicing medicine without a license. And honestly, I got that idea from you. And I believe that that's where it has to go because there are people that have no knowledge of anything that are making decisions simply based on a balance sheet and a cash flow analysis. And something else you mentioned, because I want to try to hit a lot of the things you mentioned. You mentioned
Sure.
that you mentioned your healthcare premium is X amount of dollars. Okay, well, what's funny, I just paid my healthcare premium and I realized that my healthcare premium went up 12%. And I looked back and I noticed, gee, it goes up like 8 or 12% every year. How come my rates don't go up 12% every year? In fact, Medicare's cut my rates by some percent, either a half a percent or 2% every year for 17 years, while my my own payment has gone up 12%. So
Right.
the insurance company sends out a renewal letter, and if you don't renew, you're uninsured. Why aren't the doctors sending out a renewal letter to the insurance company saying, if you don't increase my reimbursement by 12%, I can't see your patients anymore?
Well, I wanna talk about medical necessity for a minute, okay? But I wanna talk about it from a regulatory standpoint. And for me, I always like to start, some folks like to start at the end and work their way backwards. I like to start at the beginning and work my way forward. So, if you look at the first section of the Medicare statute, it's called the prohibition. And in the prohibition, it states that nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine or the manner in which medical services are provided. Now, correct me if I'm wrong, Doc, but from this, one can conclude that the beneficiary's physician should decide what services are medically necessary for the beneficiary, and a substantial line of authority should be created in Medicare that speaks to the treating physician's opinion is entitled to special weight and should be binding on the Secretary of Health and Human Services when it's not contradicted by substantial evidence. So I like to start there with the prohibition. And I'll just recite it one last time. Nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine or the manner in which medical services are provided. Thoughts?
Very well stated, and it opens up the door for a great answer. In the Medicare system, what you just stated is a facade of the truth. You are allowed to do anything you want. However, if you do it proficient, that's when the bounty hunters come knocking on your door. And then they retroactively take back everything you've done, even if it were correct, because you, by being a top 10% worker, and you should be getting a pat on the back for doing a lot of work and keeping people out of the hospital, you're now deemed a criminal and you're audited to death to either retirement or whatever horrific things happen. Now, in the non Medicare system, in the private system, everything that you read is ignored completely and the opposite is done.
That is correct. So let me share with you. So I want to share with you what is referred to as the a legal doctrine. So you're a scientist, right? And as a scientist, you use evidence-based clinical standards to make your decisions. So I want to share with you a legal doctrine by which evidence-based clinical standards are used to determine whether a treatment or procedure is reasonable, necessary, and appropriate. Okay. Now, this is Medicare's view of medical necessity that I'm talking about here. And it says, quote, medical necessity is defined under Title 18 of the Social Security Act, Section 1862A1A. And it says, notwithstanding any other provision of this title, no payment may be made under Part A or B for any expenses incurred for items or service which, except for items and services described in the succeeding paragraph, are not reasonable and necessary for the diagnosis or treatment of illness, injury, or to improve the functioning of a malformed body member. I mean, that is a legal doctrine by which evidence-based clinical standards are used to determine whether a treatment or procedure is reasonable, necessary, and appropriate. But if
Hold
you
on.
take it one step, go ahead, please.
You just used the word they are used. They're not used. That's the problem. Everything you stated was 100% true. It makes sense, but it's not used.
So you made a comment about, taking on the insurance companies. And let's be honest, that's not realistic for the typical 1 to 3 doctor or 5 doctor, or 5 doctor practice, right? The costs of litigating are just beyond what is reasonable. if you think about this, because there are cases, there is case law, there are precedents that have been set. Specifically, in the Second Circuit Court of Appeals, it was cited in the Kaminsky case, and it required the payers to define medical necessity. And the definition of medical necessity, and I think this is one of the arguments that you and I have recently used to, and I want to talk about that email to the president of an insurance company and what happened. We're not going to mention names, but I want to talk about it. So here's what it says: unless the contrary is specified, the term medical necessity must refer to what is medically necessary for a particular patient and hence entails an individual assessment rather than a general determination of what works in the ordinary case. I mean, that's rheumatology. That's hitting the nail on the head for rheumatology because we can't look at patients in a vacuum. We have to look at patients individually because not not all patients are going to have similar inflammatory diseases. They're not going to respond the same way. Some will respond better to, Orencia, or they'll respond better to Remicade, or they'll respond better to a different medication. So for an insurance company to come out and say, no, we don't want to pay for that because of whatever the reason is. We want you to use this because this is what's used in general cases. Well, there's already precedent that has been set by the Kaminsky case under the Second Circuit Court of Appeals that says, for something to be medically necessary, it has to entail an individual assessment rather than a general determination of what works in the ordinary case. I mean, what do you think about that?
You're right. The decision is right. The way you stated it is right. And in rheumatology, even if you were to take a common disease such as lupus or rheumatoid arthritis, I might be the only one in the room that would know everybody has lupus because no two of them look alike. So, how can you cookie cut and pigeonhole treatment for a room of people that have a heterogeneous disease with a homogeneous treatment? How is that possible? It's just impossible. Um, I guess Einstein would call it insanity, but that's not possible.
You're right. You're right. The last part that I want to talk about with medical necessity, and I want to get your thoughts on this because when I've written letters on your behalf and on behalf of your patients, um, I always start off by talking about generally accepted standards of medical practice. And it's defined as standards that are based on credible scientific evidence published in peer-reviewed medical literature, generally recognized by the relevant medical community or otherwise consistent with the standards set forth in policy issues involving clinical judgment. I mean, to me, there's the two most important words: clinical judgment.
Yeah,
An MBA can't make clinical judgment. Sean
no.
Weiss, regulatory compliance officer, can't make a clinical judgment. Stephen Soloway, MD, FACP, with 20 other, credentials behind his name, is the only person in the room who's qualified to make a clinical judgment. And that takes me to this other topic. Excuse me. Peer reviews. Peer reviews, and I do want to say this. I get a lot of very interesting emails from Dr. Soloway. A lot of very interesting ones. Um, that typically start off with him getting ready to jump off a cliff and me having to throw a lasso around him and pull him back just a little bit. And they usually they're very they make for great reading. That's all I'm going to say.
Well,
Um,
the book will show 50 of my letters and it'll show your forward. It'll You know what? Our team works great because we
it
get
does.
done. We succeed. We have not met a hurdle yet. where I haven't come out like a pit bull. You've reeled me back in, put it into kinder terms, and the job gets done. Now, my letter is a wake up to whoever it's meant to wake up. That person looks at my letter and says, I either need a bodyguard or I need a security agent or I need to call a psychiatrist after this guy, but he's awake. And then when you hit him with a finesse, he's like, "Oh, now that I read this other letter, this other guy's not so crazy and, he's only trying
It's
to
kind of
save
a
the
good
life."
cop, bad cop. Yeah.
Yes,
You
yeah.
know, and that raises one of the most recent issues that we had with an insurance company. And as I said, I'm not here to shame anybody.
Yeah,
They do a good enough
the
job
the
themselves.
the company doesn't matter because it's the same with all the companies.
It is, and that's what I and that was my point. So, I started off a letter to the president and CEO of the insurance company for one of Doctor Soloway's patients with saying, "One of your beneficiaries is close to death because your minions," I don't think I used the word minions, but
No.
the individuals processing or making decisions based on finance rather than on what is clinically sound medicine for a patient is resulting in a rapid deterioration of this patient's condition, and they will be dead within a matter of days if you do not intervene. And I said, I know that this is not the way that I normally start a letter off to you, but I had to ensure I had your attention. Within what, doc? 2 hours, we had a full internal investigation at the insurance company, and on the same day, we had a full approval for the medications that this poor woman was without for how long? Weeks?
It was, I think, bordering on 6 weeks.
Yeah,
It
because
was
she had an adult onset of SIDS, right?
adult onset Still's disease,
Stills, not SIDS, stills.
I was forced to use too much steroid, which, I mean, we have treatments for adult onset Still's disease and they
Right.
work. And all we wanted to do is get this woman the drug. And if she took 60 milligrams of prednisone daily, she had every side effect in the world and it was just horrible. If I wean the drug to say 40 or 30 milligrams, she's still in the steroid side effect horrible range, but her disease was flaring. The fevers, the lymph nodes, the joints, completely disabled. The lungs, I mean, every organ in her body. She was going to die. I mean, I referred to an article actually from the 1970s written by a colleague at the time or a mentor at the
Yep.
time, Antonio Reginato, who wrote an article on many cases of Still's disease and how they can die of liver failure and so on and so forth. And I mean, this would have been the classic patient. Somebody who's uncontrolled is going to die from an organ that's failing. And, you know, we went from 6 weeks of letters, from paper pushers saying no to all of a sudden the CEO investigation and the patient getting the drug all within the same day. And it
And it
shouldn't
never
have to
should
be
have
that
had.
way.
No. No, it never should have had to be that way. But, you know, this is just one of dozens in the last month to
Yeah,
2
yeah.
months of cases that, we've had to take on. And, for me, I enjoy it because as I said, for 28 years, I've been a physician advocate. I've been a patient advocate. And I believe that, we need to get back to putting patient care ahead of profits. And I know that doesn't always sound exciting to businesses like insurance companies, but at some point, you got to do the right thing because one day it's going to be you, your spouse, your child, or another family member who you deeply care about who's going to be seeking the care of a physician like Dr. Soloway. And you're going to want him or her to pull out every stop possible to save that loved one uh, that loved one's life or to restore them to a level of functionality that they had prior to whatever the onset of the current disease is. And you can't be a hypocrite and want to give care just to your family, but withhold it from everybody else who's paying your salary and those of the people at your insurance company.
Well,
The last thing that I want to talk about, because I know you hate doing peer reviews, you refuse to do them, but I've shared with you the reason why we have to do them is because if we get a provider who is not a rheumatologist, who doesn't understand rheumatology, and they have a position, you as the cerebral thinker, the clinical genius in the room with regard and respect to rheumatology, can educate that internal medicine doctor or that family practitioner. But we also have a right to request a board certified rheumatologist to engage. But the problem is there's so few rheumatologists out there that we're not going to get one. So, while sometimes you feel that doing a peer review is a waste of time, my position is, hey, let's educate them and let's refute and rebut their clinical determinations. Even though it's a waste of your time, we're still advocating for the patient. Thoughts?
couple of peer-to-peer reviews with retired pediatrician, gynecologist, ER doc, whoever. Um, I would make the point as to, I've been in practice for 20 or 30 years, and I saw the patient, and they have this, and this, and based on the following, I've come up to this conclusion, and this is the treatment. So usually what they say to me is, well, I'm looking at the PubMed version or the crib notes version of that disease, and that doesn't make sense, or that's not what's here. And of course, that's very agitating because, I'm saying, well, I'm the one who has been practicing rheumatology 30 years, and I'm the one who has seen, all the different varieties of the cases. And I'm the one who can tell you for a fact that no, you don't need a positive blood test to make a diagnosis any more than you do or don't need a fever, and how something such as a low grade fever is meaningless information, except maybe it tells you the patient's not lying. And having a high fever doesn't mean you have cancer any more than you have an infection or you have a rheumatic disease. But the people who've got these rheumatic diseases, whether it's a gout attack that cripples you and you can't get out of bed, or whether it's lupus with a pulmonary hemorrhage, or whether it's a relapsing polychondritis whose heart valves and lungs are just being destroyed, whatever it is that we're treating, or even if it's a shoulder pain in a person who can't carry their suitcase to work, why does there have to be? And I feel like I am picked on because I am more prolific than the rest. This is off topic, but when I was a rheumatology fellow at the VA, and I was one of the MCP fellows, and there were 4 or 5 University of Pennsylvania fellows, the attendings would say, everyone has to see 6 patients. Even back then, I was seeing 16 patients. So this is a workaholic gene in a guy who was trying to see more, asking the attendings questions about everything, every solitary bit of information, because I knew the minute the fellowship was over, I'd have nobody to ask questions. So I want to learn it all
Right.
then. And um, it just seems that when you do these peer-to-peer reviews, they have a predetermined answer that they're going to deny it, and then they tell you you can go to the next level of appeal. And of course, I start back by saying, well, wait a minute, we haven't had a peer-to-peer, because now that I've learned this is not a medical peer-to-peer, I should be dealing with the CEO, because this is now a financial peer-to-peer. You're telling me I can't use the
Right.
drug because it's too expensive. So let me talk to the money guy at your company, and let's figure out a money way to work it out, because they don't care about medicine at all. The patient
That's
doesn't
right.
matter at all.
Yep. All right. So the last thing that I want to talk about in our time together today, and I want to ask a sincere question. So you alluded to something about the new book called Medical Politics, and I'm going to put a link into the description for where people can get it. But you asked me to write the foreword of this book, and I never asked you why.
There's nobody better suited to write the forward. No, seriously, I'm not joking. Listen, I've been around this for 35 years. I graduated medical school 35 years ago, and in all my years, I can tell you who is the most inquisitive person. I can tell you that. Who is the most intelligent scientist? I can tell you that. Who is the most who is the most practical physician? Who is it that understands how to connect the practical physician with the really inquisitive scientist? Okay. Well, if somebody were to say to me, who who knows the most about the playing field of medical politics, it's Sean Weiss.
Thank you so much for that. So yesterday
It's
on the
true.
Wednesday,
It is
yeah,
true because
thank
even
you.
yesterday, I believe I don't know if you saw them yet. I wrote you 2 emails yesterday about 2 other patients who were being hosed over. And way back when we first became friends, I called you and I said, "Sean, I don't work Fridays anymore because I have to write letters. I'm not being productive. You know,
Yeah,
I write prolific letters that are inflammatory and they get the attention and they win. But it's a pain in the butt because I have to work. And after learning about you, it's like, you know what? You're a more refined politician version of me. I could never be a politician. I'd curse everyone out when I walked in the room. I couldn't do it because I wear my emotions on my sleeve. I don't even know, you know, I mean, I do know how to be politically correct. I do. And there's times and
yeah.
places for everything. However, you can express my anger in a tamped down way while it would take me an extra hour to re-edit my own letter 3 times. And so you I mean, look, if I'm trying to say if you said to me, "Hey, Dr. Soloway, are you saying that I fill your shoes to write your letters on your behalf?" Yeah, and you're the only person I know that can do it. And that
Oh,
goes
I
back to again.
appreciate that. I appreciate those kind words. So yesterday on the Daily Dose episode, um, I read the foreword of your new book, Medical Politics, and I talked a little bit about uh, how it kind of came around, for me to do it, and I've gotten some really incredible feedback. Of course, there's been some feedback from folks who are like, "Man, you really politicized that." Well, the book is called Medical Politics, and I went after both sides equally in my foreword. And it's not that I took a position based on an opinion. I took a position based on facts, based on actual statistics, based on those individuals who were called out in my foreword who openly admitted the failures on their behalf. So it was my opportunity to bring to as many people who are willing to read the foreword of the book an understanding of what does not get released in the mainstream media, whether it's CNN, Fox, MSNBC, or any of them. To really understand what's going on in healthcare, you have to live, breathe, eat, and sleep in this landscape. So tonight, Dr. Soloway has a book signing at 7 p.m. Is it
5 to
7 p.m.?
7. I think it's 5 to 7.
5 to 7. That's right. 5 to 7 p.m. tonight at Trump Tower in Manhattan. Uh, there is going to be a all-star cast of the Who's Who, including Pete Hegseth from Fox News, who is the MC for the evening. Um, Always admired him for his years of service to our country. Uh, Really admire his level-headed approach to delivering the facts of what's going on. Lindsey Graham will be there, and Mike Crispy will be there. And my understanding is that there may be a few other individuals with some pretty powerful names who will be there, but we will have to wait and see. And I don't want to give away too much about what's going to transpire tonight at Trump Tower between 5 and 7. But I can tell you this: I am excited to give my friend a hug. I haven't seen him in a few months, and to get to watch him shine in his moment of signing copies of his latest book, Medical Politics. Dr. Stephen Soloway, the man, the myth, the legend, the Babe Ruth of rheumatology. Thank you so much for carving out the time that you spent with me today and my audience to talk about your new book, to talk about what's going on in the world of rheumatology and in medicine in general, and helping to bring a level of sanity to an insane industry.
Well said. I really hope that I can help people because all of us actually are patients. It helps people that will be a patient one day understand the weather and the terrain and how to navigate through any weather and any terrain, and with the right wording or the right person to speak to. And that's the sad thing. You shouldn't have to have the right wording or anything. You should just go to the doctor, get diagnosed and treated. But as we've been discussing for an hour, that just isn't how it is anymore. And
Right.
so I'm hoping to both solidify and weld together the world of what's going on, what should be going on, what was going on, and why it's broken, how it can work, and why it has to work. And at the same time, educate the regular people on common topics that they may encounter as they pertain to my field. It's very sad to see that good doctors, really good doctors, are retiring because they just don't want to deal with it. They
Yep.
are they are just quitting. And you cannot this isn't a football game. You cannot take the scabs and expect them to know as much. You just can't do it because they don't have the experience.
Yep. All right. Great way to finish out this segment. All right, y'all. We will be off on Friday, the 28th of October, as I will be in New York City, as I said. And we will be back on Monday, the 31st of October, which is Halloween, with our coding and compliance roundtable. We have some fun stuff planned for our viewers. We have some incredible topics, some incredible guests. As always, thank you all so much for tuning in, logging on, and hanging out with me just for a little while. And until tomorrow, remember, be good to yourself, but more importantly, y'all be good to each other. Take care.